Good evening, everyone, and welcome to our first O'Brien Lifehouse CPD series in 2023. I'm very excited to welcome you to our hepatology medical update, which is topic for tonight. My name is Lydia Koenig. I am a program officer here at Central and Eastern Sydney PHN, and also working with us tonight, Sue Moxon, Planning and Engagement and CPD Program Officer. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognize the continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I would also like to acknowledge Aboriginal colleagues joining us tonight. But before we move on to our main presentation, I would like to invite Tammy Shapiro to give us an update on liver health pathways. Tammy is a reviews project officer and health pathway to Sydney. Thank you, Tammy.
Thank you, Lydia, and hello, everyone. Now let's see if technology is going to be my friend tonight. Bear with me. How's that looking, Lydia?
Excellent. Thank you very much.
Thank you so much. And thank you so much for having me. I'd also like to commence by acknowledging the traditional custodians of the land on which we gather here tonight. Pay my respects to elders past, present, and emerging, and any Aboriginal or Torres Strait Islander colleagues here with us this evening, excuse me. So I think a lot of you in the audience will be familiar with health pathways. This is just a quick recap. As CESPN's in a very unique situation, we actually have two health pathways regions. So our GPs are well covered by two separate health pathway sites. We have the Southeastern Sydney Health Pathway site, which covers the Southeastern Sydney LHD region, including the Sydney Children's Hospital Randwick and St Vincent's network. And then we've got the Sydney Health Pathway site, which covers the Inner West and Central Sydney region. So our lovely guest speaker tonight is focusing on some of the more Sydney LHD services. But I just wanted to give you a quick recap of the liver and other hepatology pathways that are across both sites. To use health pathways, for those who aren't familiar, the easiest way, once you log on, just search for what you're looking for, pick the relevant pathway that you want to explore. To get the most out of the pathway, or if you're looking for something in particular, just one particular, say, medication or investigation, we recommend you expand all and then hit the Control F and type for what you're looking. So as the example in the slides here, I've just popped in decompensation relevant to that condition, and the pathway will then highlight all instances where that word appears. So in terms of the question we get is, well, which health pathway site should I use? You should use whichever site based on where your patient will be accessing services. So even if you're a GP and your practice, say, is based in Mascot, so you're within the Southeastern Sydney Local Health District catchment, but you are referring to RPA services, for example, you'd be welcome to use Sydney Health Pathways, and vice versa if you were in the Inner West, but you were accessing, say, Sydney Children's Hospital services. Usage is interchangeable, and the username and password for these sites, Sydney and Southeastern Sydney, are now interchangeable as they both come under the CESPN catchment. So from the Sydney perspective, we've got quite a range of liver condition pathways. The lovely speakers that are here tonight have worked very closely with our team, and I extend my thanks to them for their ongoing support of our program. We've got a couple more updates trickling through. So if you notice something that's not 100% right there, it's coming, I promise. So there's a nice range there, and hopefully guide you in terms of managing these conditions within your patients. I just wanted to highlight as well that for Sydney, e-referral is also available. So for both the RPA, gastroenterology and hepatology, as well as the Concord gastrology and liver service, e-referral is available using HealthLink smartforms, which you can access through your medical software. So that includes Best Practice, Medical Director, and Genie. Or if you don't have that connection, it can be done via the HealthLink portal. I've popped a little email address there, and these slides will be coming out to you in case you don't have time to copy that down. For anyone who's got queries about e-referral in particular, please reach out to that email address there. I'd also like to quickly highlight Health Pathways Sydney is currently running a survey. We are looking to get feedback from our wonderful GP users, and that includes GP registrars, those who are based in the Sydney LHD catchment, and I've just highlighted a little map there. I know that the boundaries can be a little bit confusing at the best of times. So those working in that region, whether you use Health Pathways or not, we'd love to hear from you. Those who complete the survey can also enter the draw to win a $100 gift voucher. And in particular, this survey is looking at some questions in particular about diabetes services. So it's part of an ongoing improvement project that we're running to improve the way that we maintain and update content, which, as we know, is incredibly important to making sure that GPs have the right information for their patients to direct them to the right services as applicable. Those who fill out this survey can also fill in an expression of interest to participate in a more detailed interview, and you will be remunerated for your time at $130 an hour if you participate in that interview. From my wonderful Southeastern Sydney colleagues, they also have a wonderful range of hepatology and gastroenterology content. Of course, these are then aligned to their hospital services within their catchment regions. So there's something for everyone. Last but not least, some program contact details. Should you want to reach out, any questions, have a tutorial, how do I use this? How do I get the most out of this? Raise some feedback. Alternatively, as I've put down the bottom there, anyone can send feedback directly from the site. On every single Health Pathways page, whether you're in the Sydney site or the Southeastern Sydney site, there is that send feedback button that comes straight to the project team. It gets triaged, and we aim to respond to that as soon as we can so that we can facilitate your inquiries. That's it for now, Lydia. Thank you so much, and enjoy tonight's presentation.
Thank you very much, Tammy. Looking forward to hosting you again at our upcoming events. And now over to you, Dr. Edmund Lee. Thank you.
Thank you, Lydia. So, welcome everyone. Thank you for joining our webinar tonight. This is the first of the year for the PH and CPD. I believe the next one will be a face-to-face, and that's for next month. So tonight, we have two speakers. Our first speaker is Associate Professor Simone Stresser. Simone is a Senior Staff Specialist at the A.V. Morrow Gastroenterological and Liver Centre and the Australian National Liver Transplantation Unit at RPA Hospital. She is the past president of the Gastroenterological Society of Australia and a current board member of the Liver Foundation. The foundation is an Australian community organisation to support people with liver disease. Simone has a major clinical and research interest in primary liver cancer, viral hepatitis, non-alcoholic fatty liver disease, advanced liver disease, and liver transplantation. She is a director of hepatology clinical trials at RPA Hospital. Simone is committed to raising awareness of the rising burden of liver disease in the community and the important role of early interventions to improve outcomes. Her publications include many book chapters and over 190 publications in peer-reviewed journals. Her talk tonight is on the paradigm shifts in the care of patients with advanced liver disease. So please welcome Associate Professor Simone Stresser. Thank you.
Thank you so much, Edmund, and thank you to the team for inviting me to speak tonight. What I really wanted to cover was aspects of advanced liver disease, how you can diagnose in your practice, how you can get confidence in referring, but also how you can co-manage patients with more advanced liver disease in primary care as well. I'm going to share my presentation. It's got some cases. Hopefully you can see that now. I'm hoping. Is that sharing?
Not yet.
Yeah, I just realized that. Just sorry about that. Yeah, that should be sharing now.
Thank you.
Thank you. Sorry about that. So I really wanted to look at some things you may not be aware of. So as you saw, there's a lot of information on the health pathways that will help you with it. And I really do urge that you use that, because that gives you a lot of the triggers and a lot of the background information. But I kind of wanted to focus on some of the things that are really shifting in advanced liver disease, and particularly the role in primary care of keeping people out of hospital in the first place. So trying to prevent some of those complications that can land people in hospital, but also to prevent readmissions. And we'll get to that towards the end. I do have some disclosures as is shown on this slide and have been mentioned. So what is a paradigm shift? Well, it's an important change that happens when the usual way of thinking about or doing something is replaced by a new and different way. And that's what I want to sort of focus on this evening, to give you some different ways of thinking about liver disease and thinking about your practice and what you're doing on a day-to-day basis. There is certainly an unrecognised burden of liver disease in Australia, and these are some slides really taken from the Australian Institute of Health and Welfare, pointing out that liver disease is now the 11th leading cause of premature death in Australia, and this was data from about 10 years ago. It's mainly in men, so more than 2 in 3 premature deaths are due to liver disease are in males, but we're seeing a decrease in death rate, and that's because we've got better treatments, we've got earlier recognition, and we're preventing some of this stuff, and we want to continue to do that. So among men aged 45 to 65, chronic liver disease is among the leading 5 specific causes of disease burden, and you may not have been aware of that. And so on that lower slide there that you can see, this is a disease of middle-aged people. It's not a particularly disease of older people. They've usually died by then. So it's a disease of men and women in their working ages and really peak working ages as well. So in the ages of 45 to 65. And people getting sick, and that's when we're starting to talk about transplant and all those things at those ages. So some of the myths I kind of wanted to dispel in this session is really to look at some of the things that you may think about, and you may think you know which patients in your practice have cirrhosis, and I would challenge you to that, because I don't think most of you are probably actively looking for cirrhosis, and by the time they're diagnosed, they probably could have been diagnosed 10 years earlier if we'd been thinking about it. You also might think that all patients with cirrhosis have symptoms and signs, but this is a silent disease and it can come on, and you might just pick it on their biochemistry and their hematology. They may not come in complaining of anything. Patients with cirrhosis who deny alcohol use must be closet drinkers, and in fact, the most rapidly rising cause of liver disease in the country is metabolic-associated fatty liver disease related to the obesity and diabetes epidemic. Cirrhosis is irreversible and has a poor prognosis. I'm going to show you that many of the manifestations of cirrhosis are in fact reversible. The scar tissue may stay, but it may get less with intervention, and the manifestations may be reversible. And prognosis can be significantly improved by what we do. The care of patients with cirrhosis should be hospital-based, or it can't be. There's not enough hospital clinic time, enough hospital specialists. It's got to be centered in primary care. Another shift is around the myth that there are no treatments that can change the natural history of patients with cirrhosis. And we've now got major interventions that can have major impact on these patients. Some things that you probably think all the time is that statins and paracetamol should be avoided in patients with liver disease. And in fact, statins have got major benefit in liver disease, and paracetamol in usual prescribed doses is perfectly safe. Smoking, you might think, has nothing to do with liver disease. In fact, it does. It impacts fibrosis and fibrosis progression, and patients should stop smoking. And you might think that all patients with cirrhosis need a transplant or they will die. And in fact, many of the patients referred to me for transplant assessment, I can get better through lifestyle modification and medications. So we're going to look at a couple of cases. The first is Mary, who's a 60-year-old woman who presents for routine checkup. She has long-standing obesity with a current BMI of 34, long-standing type 2 diabetes, hypertension, hyperlipidemia, and all the other features of that you associate with obesity. She's got osteoarthritis, gastroesophageal reflux, and she's had an ultrasound a few years ago that said that there was fatty infiltration of the liver, and she denies drinking alcohol. So I'm absolutely certain that Mary is very familiar to you all. She's a very typical patient that we see with long-standing obesity and metabolic risk factors. And she's on the typical drugs that you would expect for somebody with those risks and metabolic profile. She's on metformin, glycoside, perindopril, atorvastatin, pantoprazole, and paracetamol for her osteoarthritis. She has blood tests, and there are some concerning features on these blood tests. And in particular, her albumin level's a little bit low. Her liver enzymes, so if we look at alkaline phosphatase, GGT, ALT, and AST are all up a bit, but not dramatically so. There's not a severe, acute liver injury going on here. And we might notice that the AST is higher than the ALT. And that raises a few flags. One is a concern for cirrhosis, and that's a pattern that changes in cirrhosis, but also changes in people who are drinking a lot of alcohol. Her renal function is okay, but she's clearly got diabetes with an HbA1c of 8.2%. It's poorly controlled. And importantly, on full blood count, her platelet count is a little low at 130. And I challenge you to look at people with these profiles and look at the platelet count and look at the platelet count over time. And as a hepatologist, I see people coming in with a platelet count maybe of 80 or 90, but when I look back on their profiles over the last 5 to 10 years, you can see the progressive fall from the mid 200s down to the high 100s, then to 150, 140, and it's just progressively falling. And the clues are in that progressive fall as liver fibrosis progresses and there becomes some splenomegaly. We always, in anybody with liver dysfunction, do viral serology looking for chronic hepatitis C and chronic hepatitis B. And again, there's very good health pathways that will support you in the management of those conditions if you identify them. And I'm not going to go through that. So clearly she's got chronic liver disease. I've just taken through all those features that say that she has got chronic liver disease. The question is, does she have cirrhosis? And can you diagnose cirrhosis in primary care? Well, the top causes of chronic liver disease are here. The top 4 are the ones that we see most commonly in the community. So it's metabolic associated fatty liver disease, alcohol-related liver disease, and still viral hepatitis, hepatitis C, and hepatitis B. And if you're working in a practice that has a lot of patients from Asian countries, you might see a lot more hepatitis B than hepatitis C. If your practice has a lot of people with a background of injecting drug use, etc., you may see more hepatitis C. But as you know, we've treated a lot of people with hepatitis C, and a lot of people have been cured in the last 6 years or so. And occasionally we'll see other weird and wonderful liver diseases, but they're much less represented than the top 4. So the vast majority of people that you'll see in your practice who have just mildly abnormal liver enzymes, it'll be the top 4. And the others may occur in perhaps younger people or where the pattern's atypical. All of these can lead to cirrhosis, and all patients with cirrhosis ultimately can develop liver failure and liver cancer. Now, you heard me talk about metabolic associated fatty liver disease, and this might be a new term to you, and it's a new term that's been promulgated by Professor Jacob George and colleagues at Westmead Hospital, but promulgated internationally to replace this term of non-alcoholic fatty liver disease and the recognition that you can have metabolic associated fatty liver disease as well as drink alcohol. So it makes no sense to have a diagnosis of non-alcoholic liver disease and alcoholic liver disease at the same time. So metabolic associated fatty liver disease is a really attractive term, and it can be a positive diagnosis. So we abbreviate it as MAFLD. And we can make a positive diagnosis when we see fatty liver on an ultrasound or mildly abnormal liver test consistent with fatty liver in someone who is overweight or obese. And that in itself can lead to a diagnosis of MAFLD. In people with type 2 diabetes, and particularly if you've got the 2 in combination. And we can also make the diagnosis in people who are lean or of normal body weight who have other metabolic risk factors, and they've got to have at least 2 of those metabolic risk abnormalities. And then we can make this positive diagnosis of MAFLD rather than a diagnosis of exclusion. And I think that's really important. So clearly, Mary with her type 2 diabetes and her long-standing obesity and fatty liver on her ultrasound has MAFLD. Even if she's got another condition, she's still got MAFLD, and that's what we're going to focus on. So the question is, how do we know if Mary has cirrhosis? Well, we certainly examine her, but often it's challenging in someone with obesity, all these comorbidities. So the physical examination may be a little limited. You may not be able to feel organomegaly, for instance. We'll look at a blood test. We want to look at the platelet count. Again, it's really important to do that full blood count. Look at her albumin level, look at the AST to ALT ratio. Look at her imaging, and that may be ultrasound in the first instance, as shown on the left here, where we may very clearly see a nodular outline of the liver. And the ultrasound report will suggest that there's fatty infiltration in a nodular liver, maybe with portal vein enlargement and splenomegaly. And of course, a CT scan would show similar features. And we can do non-invasive assessment. And the ones that I'm going to focus on, I've highlighted in blue here, particularly one called the FIB4. And this is a test that you can run on an app on your iPhone and or your computer. And it is just based on age, AST, ALT, and platelets. And so you only need to know the age, platelets, AST and ALT, plug them into the number and we'll get a FIB4 score. And this helps you to risk assess whether patients are at low risk of fibrosis or at high risk of advanced fibrosis or cirrhosis, or they're somewhere in between. And for the somewhere in betweens, we certainly recommend they have transient elastography if you can access it. There will be other serum markers that come along, and there are applications in for Medicare funding for something called the HEPA score and the ELF score. And these are panels of liver biomarkers that are also closely correlated with the presence of advanced fibrosis and can exclude advanced fibrosis. And occasionally we still do liver biopsy, but really not so much anymore, because we can usually identify the presence of cirrhosis just by using these non-invasive markers now. So this is the FIB4 that I just showed you about. You can access websites with it, and you can access it on MedCalc and various other calculators. And as I said, for Mary, we've just put in the age, the AST, the platelet count, the ALT level, and it's calculated a FIB4 score of 4.57. And when we look at the algorithms, we can say if the FIB4 had come less than 1.3, then she would have a very low risk of having advanced fibrosis. But at 2.67, she's very likely to have advanced fibrosis. And the higher the FIB4 score, the higher the risk of fibrosis and cirrhosis is. So she's got a high FIB4, puts her over here. Already we're thinking very likely to have cirrhosis. So she has had that FIB4, that's 4.57. We also do a FibroScan on her, and she gets a FibroScan score of 26 kilopascals, which, as you know, if you've been using FibroScan, for instance, in your hepatitis C practice, then that's a very high score. Normal would be 4 or 5, and it goes up to 75. She also has an ultrasound showing a nodular liver, coarse and decotexture splenomegaly, and she's got some perisplenic varices. So everything here is pointing towards cirrhosis, and everything is pointing towards cirrhosis due to MAFLD. So we're pretty confident she's got MAFLD. She may have other things as well, but she's certainly got MAFLD. She's got clear features of cirrhosis. And then the next question is, has she got compensated or decompensated cirrhosis? And what are they? And how do we tell the difference? And therefore, what are the priorities in her management? And for every single patient with cirrhosis, we have to make priorities in management and decide where that management will be and what the long-term management plan will be. So we still use scores, and I know you all have heard of the child score, now called the Child Toolkit Pew score, or the Child's Pew score. You might hear it in different nomenclatures. And basically, it's just assigning 1, 2, or 3 points to the degree of ascites, encephalopathy, bilirubin level, albumin level, and INR. And we come up with a score of 5 or 6, which would be child's A, which would be compensated cirrhosis. If there are 7 to 9 points, it would be early decompensation with a child's B, and getting 10 to 15 points would be more advanced decompensation or child's C cirrhosis. And Mary has 6 points because her albumin level was a little bit low, so she's still compensated, but she has a slightly low albumin, so she's not quite as good as if she'd had a higher albumin. And a patient with child's A cirrhosis over the next 2 years is very unlikely to die of it. They've got a 90% survival. Whereas once that child score starts getting higher and is getting to child's C, you can see that the survival is much less. So she's got a child score of A6. However, she's had no decompensation events. And when we talk about decompensation events, we say she's had no varicose bleeding, no hepatic encephalopathy, and no ascites, and they're the key decompensation events. So that means, based on the child score, we think she's compensated, and the fact that she hasn't had any of these features, she's got compensated liver disease as well. And our job now is to prevent those things happening, because once those things start happening, things start falling apart. So you can see here that if you're compensated but have no varices, 1% 1-year mortality, very, very low. Once you've got varices, it goes up a little bit, but once you start to develop ascites, variceal bleeding, infection, renal failure, and all the other consequences of advanced liver disease, you can see the mortality goes up rapidly. And they're the things that we want to prevent, and we can prevent all of those things from occurring. So that's what I really wanted to take you through in terms of preventing those things in people who currently have a diagnosis of cirrhosis, but it's not making them sick. It's just something we've diagnosed early in our practice. So we do recommend, and you'll see in Health Pathways, that all patients with a diagnosis of cirrhosis should be referred for specialist management, and that obviously the clinic at RPA, at Concord, and St George, and the other major hospitals. We all do like named referrals where possible, I'll say, but we do want, when you do that referral, that you're not just handing them over, you're going to remain involved. Hopefully there'll be good communication back from the hospital, and you're going to stay actively involved in their management, monitoring their diuretics if they're on it, etc., and making sure they're undergoing their regular surveillance, because we all want to make sure that Mary and others like her are provided ongoing optimal care. And really to reinforce that appropriate management at this early stage of her liver disease or her cirrhosis can prevent progression to hepatic decompensation and all the poor outcomes associated with that. So the things that we're thinking of that we need to be treating, we treat hepatitis C in people with cirrhosis. We can prevent future decompensation and it significantly extends survival. Likewise with hepatitis B. So all patients with hepatitis B with cirrhosis need to be on antiviral therapy, and that's lifelong antiviral therapy. Patients with MAFLD, like Mary, need to lose weight, but under close supervision, maintaining their protein intake and their muscle mass. It's really important. So that needs to be linked with exercise, if you can get them to do that. Must control diabetes, and drugs such as metformin and statin both have positive health benefits in patients with cirrhosis. And in fact, metformin has been associated with a reduction in risk of liver cancer, and statins have a reduction in the risk of progressive portal hypertension. Both very interesting. So they're good drugs in cirrhosis unless there's renal failure or other contraindications. Alcohol abstinence is critical. Patients who have got a diagnosis of primary biliary cholangitis, and you might have some of those in your practice, the use of ursodeoxycholic acid has significantly reduced the need for liver transplantation. And a new drug, which is on the PBS, which has to be prescribed by specialists, but is also potential for significant benefit, is obeticholic acid or Ocaliva. Patients with hemochromatosis, not that common with phenotypic, but they need to be on phlebotomy, as you know. Patients with autoimmune hepatitis need to have a positive diagnosis, and they will mostly require lifelong immunosuppression, but hopefully at low dose. And patients with Wilson's disease or copper overload can turn around decompensation significantly with appropriate chelation therapy, and certainly prevent cirrhosis and decompensation. The metabolic features that these patients have are additive, and the more metabolic features that patients have, the more their risk of progression of liver disease, and particularly the development of liver cancer. So this was a study showing that the more of these metabolic risk factors you have, the more risk for liver cancer. And by the time you've got type 2 diabetes and obesity and hypertension and dyslipidemia, you've got an 8-fold increased risk of getting liver cancer in the setting of metabolic associated fatty liver disease. And liver cancer, disturbingly, in these patients can occur in the absence of cirrhosis. Doesn't mean we survey every patient with metabolic associated fatty liver disease, but we try and pick out patients with more advanced fibrosis or cirrhosis and engage them in surveillance for liver cancer. We also, in our clinic, and this is not so much in primary care, but in our clinic, we use FibroScan, not just to diagnose cirrhosis, but also to risk stratify who's at risk of complications. And the higher the FibroScan score, and you can see here over 25, we can assume that that patient has clinically significant portal hypertension, and they're therefore at risk of complications such as bleeding from varices. And we use this information to decide on mitigating strategies, such as starting a non-selective beta blocker. So it's not just using FibroScan to sort of figure out who's in the cirrhotic range, but then who's in the higher levels of FibroScan scores who may be at higher risk of further complications, and that we've got to introduce other strategies. So Mary, remember, has a platelet count of 130. She's got a FibroScan of 26, and she's got evidence of varices on that ultrasound. So we can do one of two things at that point, because we know she's at risk of having varices, and people with varices are at risk of bleeding and dying from that bleed. So we can either refer for the gastroscopy to identify varices, Or we can assume she's got varices because we know the ultrasound showed some varices. We know her median liver stiffness is high, and therefore we can just put her on a non-selective beta blocker, and the data for carvedilol is actually better than propanolol that you might be familiar with. And if I put somebody on carvedilol, I don't need to do a gastroscopy because I'm already managing their risk for variceal bleed, because in fact, that's the most effective strategy for preventing a first bleed. So they go on to carvedilol. And there's other benefits of carvedilol apart from preventing that first bleed. It also prevents progression to ascites and other features of decompensation. So someone like Mary with a high FibroScan score, clinically significant portal hypertension, which is what CSPH stands for, if they go on carvedilol rather than having no treatment, we see a 49% reduction in decompensation or death and a 58% reduction in developing ascites. And as I mentioned, carvedilol seems to be better than propanolol. So we try to get these patients onto a target dose of 12.5 milligrams daily if they can tolerate it. And that's actually quite a low dose. You'll know the cardiologists and patients with heart failure will be using 25 BD. So 12.5 a day is quite a low dose, although some patients still don't tolerate that. And we try to get them onto the minimum dose. Once they're at 12.5, they don't need to push any higher. But if they have hypertension and they have some of the indication for treatment, you can use carvedilol at a higher dose to manage other things like hypertension. So she should have a gastroscopy to screen for varices if she can't or won't take carvedilol. And some patients refuse to take beta blockers, sadly, in which case she should have a gastroscopy, because if she's got large varices, they'll need to be managed in another way. So again, getting patients into the system so they can be really targeted with treatments that can be life-saving. So the priorities in her management, somebody with compensated cirrhosis, are treat the treatable. So treat the underlying cause of the liver disease. And again, health pathways will give you good direction in hepatitis C and hepatitis B management. Of course, they'll need specialists, probably interventions around starting treatment in autoimmune hepatitis PBC, but interventions are very effective. And you have a major role in making sure patients are linked with care around alcohol dependency and alcohol-related consequences such as liver disease. We want to ensure complete abstinence from alcohol, therefore, and that's not just a reduction in their drinking, it's complete abstinence if we can get them to that. And smoking cessation is really important as well. Optimized management of their diabetes and their overweight and obesity, and a really important attention to diet. And patients sometimes freak out when you tell them they've got all this. And I've just had one recently who completely freaked out and went off and basically completely restricted their diet. They cut out everything and they've just been eating fresh fruit. That's been great. It's really brought on diabetes that they didn't already have, and they've developed sarcopenia very, very quickly, because this is a catabolic disease. And if you stop eating protein, you'll break down muscle very, very quickly. So they do need to reduce their sugar intake, hopefully have low fat choices, but maintain high protein and the otherwise balanced diet, fresh fruit and vegetables, and keep the processed foods pretty low. Challenging to do, as you know, in the current environment, because the processed foods are the cheaper ones. We're also going to recommend regular exercise, and keeping that muscle on through exercise is really, really important, as you know, in diabetes and obesity management as well. We're going to ensure appropriate surveillance for complications. Again, that engagement with the liver specialist clinics and specialists. HCC surveillance with 6 monthly ultrasounds, with or without AFP. The most important test is the ultrasound, actually, but if they're having blood tests and AFP, 6 monthly is a useful adjunct as well of a feta protein. And they need to have their liver function monitored regularly, and it depends what they're on. If they're on other drugs that they need to be monitored regularly, for instance, that might be every 2 or 3 months, or it might be every 6 months when they have their ultrasound. And we want to reduce the risk of complications. So I've mentioned non-selective beta blockers to prevent both variceal bleeding and decompensation, but continue drugs such as metformin and statins because they've got extra benefits. And I've mentioned here about PPIs. We want to de-escalate PPI use. It's got an adverse effect on the microbiome and increased risk of infection and hepatic encephalopathy in patients with cirrhosis. So where possible, stopping PPIs, although in this obese population, it's quite challenging because they've also got reflux. So that's all about sort of the patient with compensated disease that's hiding in your practice and that you haven't recognized yet, really, because they don't have symptoms, they don't have too much going on. It's all in the blood tests at this point. And then we move on to someone like Peter, who's another patient you might see, where the features of cirrhosis are more obvious. Although I'm surprised sometimes when I get referred patients that they've been lurking out there with really advanced liver disease, wasting away. And by the time I see them, are profoundly malnourished with multiple stigmata of liver disease. But here's Peter. He's presented to you feeling tired and lethargic. He's got poor sleep, poor concentration. And he comes in saying he's actually concerned he's putting on weight because he's been on the scales and he's going up on the scales. Well, that's because of all the ascites he's developed. Because you can see in this picture here, he's actually quite malnourished and he has quite marked ascites. So the scales don't really tell us. And he's got multiple stigmata of chronic liver disease. He's skinny with loss of muscle bulk, but he's got ascites edema. And I've put here, look in their mouth, because often this is associated with poor oral health and particularly periodontitis. And often these patients haven't been near a dentist for years. And COVID's made all that worse as well. And periodontal disease drives inflammation and drives liver disease manifestation. So it's really important to get them into dental care. And I'll come back to that. Relevant history, he's been drinking 6 schooners of beer a day. He's been smoking 10 cigarettes per day. He's been eating poorly and all the things that go with that. So he's clearly got features of decompensated cirrhosis. And again, I mentioned the teeth and I'll keep coming back to this. He's got terrible dentition. And we often as doctors don't look in people's mouths, and we really need to get them engaged in good dental care and get all that cleaned up. And we do in our service a lot of dental extractions when there's a lot of rotten teeth. And in fact, people will get better once we remove a lot of their rotten teeth. So again, treat the treatable. In Peter's case, it's alcohol dependency and his smoking. We've got to exclude, again, viral hepatitis. So again, they need to be screened for hepatitis C and hepatitis B, and we treat either of those if they're present. We need to assess and manage the malnutrition. So we need to get someone like this on a high protein, high energy diet. We need to get the dental disease assessed and treated. We need to manage his ascites. We need to do surveillance for complications, and we need to prevent further decompensation. So we want to try and undo what's there, and we want to prevent it getting worse in the future. So really, we need to recognize that many of the features of advanced liver disease, even at the point that Peter presents, can be reversed, and his outcome can be significantly improved if we do the things on this list. And we really need to avoid nihilism. And I think there has been a lot of nihilism in this space before. Oh, he's just got liver failure from alcohol. There's nothing we can do. He's going to die of it. And in fact, if we can engage Peter and similar into really actively managing these issues, we can turn this around. But it's going to take work between you and us at the hospital level. So it's essential that patients with any form of alcohol-related cirrhosis particularly abstain from alcohol, and reduction in alcohol consumption with abstinence is a less clear benefit. And so the benefits that we see, the patients with cirrhosis who have medical addiction therapy have a significantly lower risk and incidence of hepatic decompensation. So if they haven't ever had liver failure, if you can get them into medical addiction therapy and get them abstinent, they have a significant benefit and are much less likely to develop decompensation in the future. Patients with decompensated cirrhosis who abstain from alcohol have improved survival, and that's been shown in various studies as well. And patients with compensated cirrhosis who abstain from alcohol have a reduced risk of developing liver cancer. And you can see that here there's a 65% reduction in the chance of developing liver cancer if they can maintain abstinence. So lots of reasons to really, really aim to get these patients abstinent of alcohol, not just send them away with a message to cut down a bit, which we often hear about. And we need to focus on high protein foods, whether that's animal-based proteins or plant-based proteins, depending on the patient. And we can supplement that. And for instance, through our service, we've got funding to supplement that for the patients that need it as well. But we can do this through dietary measures as well. And this is just a patient of mine that gave me consent for his photos against my door in clinic. You can see the first time I ever met him, he's skinny, he's got huge ascites, he's very malnourished looking, and this was due to hepatitis, not due to hepatitis C, it was largely due to alcohol and eating poorly. And with attention to diet through a high protein, high energy diet, he had one more paracentesis to drain fluid, but he completely abstained from alcohol from that point forward. And you can see over the next 6 to 12 months, he's completely recompensated clinically. His tattoo's getting wider as he puts that muscle bulk back on, and he's got no more ascites. He's got a bit of a hangover from his previous abdominal distension here, but no ascites, and he's filling out. And he's never ended up needing transplant. He was actually referred for transplant here, and we turned this around really through lifestyle modification. So what about his poor oral health and his periodontitis? Well, I've already mentioned that this is really something we should be looking for and really, really focusing on, because poor oral health is associated with all the complications of cirrhosis, including ascites, encephalopathy, hydrothorax, which is fluid developing around the lung, frailty, hospitalizations, all-cause mortality and liver-related mortality. And so we do pull out rotten teeth, we get them into good periodontal care, etc. So we need to gauge that. And if they don't have access, because for financial reasons, to community-based dental care, if they're cirrhotic and they have these problems, we can get them through the hospital clinics as well. Management of ascites, you probably know some of this, but we start with dietary measures, a low sodium diet. We can start diuretics, and usually a combination of spironolactone and furosemide together, gradually increasing the dose and monitoring for side effects and for electrolyte and renal dysfunction. And we can then, if it's not getting things under control, we can do large volume paracentesis, and all our centres have got now ambulatory paracentesis. They don't need to be admitted to hospital. They don't need to come to the emergency department unless they're really compromised. And we do this every week. We can tap for patients, sometimes more if we need to, at RPA. The other hospitals have similar arrangements as well. They get intravenous albumin. They stay for about 3-4 hours and they go home. And we, at the same time, work on their nutrition, trying to improve their muscle mass, and that will significantly reduce their need for further paracentesis. Sometimes we need to do a TIPS, where we put a transjugular intrahepatic portosystemic shunt. It's just a little mesh stent that the interventional radiologists insert from the hepatic vein. So they go through the neck, down into the hepatic vein, and put this artificial stent across into the portal vein. That instantly decompresses the portal hypertension. So now blood comes up through the portal vein, through the tips, out through the hepatic vein, and immediately reduces portal pressure, will resolve their ascites. They'll then be able to eat, put on their weight, and it can also reduce their risk of bleeding. And we use it sometimes in patients who are bleeding. And of course, some patients need transplant, we'll get to, and I've mentioned diet, and also the need for a late evening snack. Obviously, diuretics have complications, and we need to monitor for these. The ones that patients don't like, they don't care about all this stuff, but they don't like the gynecomastia that complicates spironolactone, and they really don't like muscle cramps, which can be very, very painful and come on any time. So we need to monitor, obviously, to prevent all these problems, but we also need to be aware that the patients don't like them because of these issues, and often won't take them because of those issues. One of the things that's very easy, you may not be aware of, and then we've studied and shown is effective in patients with cirrhosis and painful muscle cramps, is the use of taurine, which is an amino acid. They can buy this online, either a powder or compound into capsules. The dose is 1,000 milligrams twice a day, and it's significantly reduced the intensity and duration of cramps in patients with cirrhosis, as we showed. So that's something easy that patients can do. Another thing that we see, and this is a paradigm shift again, is that we're now using albumin in our outpatients with decompensated cirrhosis to prevent further complications. And you can see in this study of patients who were receiving albumin, two little bottles of concentrated albumin twice a week for 2 weeks, and then 2 bottles every week, IV. So they come into the clinic, they get their bottles of albumin, they go home. And those patients who got that had a 38% lower all-cause mortality at 18 months, a 52% higher rate of being free of paracentesis through the study, and a 57% lower incidence of refractory ascites, where they've got to keep coming back for TAPS. So major health benefits again, while we combining this with the other measures I mentioned, but they're getting on to regular albumin infusions, which of course we'll initiate in the service, but you may be wondering why the patients come in every week for an albumin infusion, because that's not what we used to do. But we've been doing this for the last 2 or 3 years or so. We can prevent that first variceal bleed, and I've already mentioned the use of non-selective beta blockers such as carvedilol, which is the most effective strategy for preventing a first bleed. But if they can't tolerate that, we can put on little rubber bands over their varices and include that. But doing this measure doesn't do anything for the portal pressure in their liver. So we like to use carvedilol where possible, but some patients will end up with banding. And if they've had a bleed, they'll certainly be banded. and that's done in conjunction with carvedilol. So you'll see patients who do present with a varicose bleed, they'll have banding in hospital, and they should be discharged on carvedilol or propranolol. And it's really important that that medication is continued long-term. Don't just stop it. It's not they go home with a 5-day supply, but they'll come back to you to get their ongoing supply of that. And it's really important that it's continued to prevent that next bleed. Encephalopathy, again, I'm sure you're aware of, it occurs in 30 to 40% of patients with cirrhosis. It's associated with poor prognosis, so 64% one-year mortality once patients are starting to develop encephalopathy, where they're vague, confused, disorientated. They need to come into hospital with overt features. And it's associated with a reduced quality of life, obviously. And there's a significant burden on caregivers and family members. So we really need to assess the whole social milieu. It's not just about the patient, it's about their partner, about their family. Everybody's very stressed. Often these people, if they're getting, they're at home, but they're getting recurrent episodes of encephalopathy where they'll get very confused. They might let themselves out the front door, go and wander in the neighborhood. It's a dangerous situation. Certainly can't drive. We've got to have that discussion with them, but it's an incredibly stressful period. And there's measures that we can do to manage hepatic encephalopathy. So we start out with medical measures such as lactulose, that's been around for years, and we're dosing that to enough dose through the day so they're having their bowels open maybe 2 or 3 times of soft bowel motions. We don't want them getting liquid diarrhea. And you'll see the patients who have encephalopathy that gets them into hospital will be started on rifaximin. And that's, again, a long-term medication. So you need to make sure the patients are continuing to take it. It's not just a short-term one on discharge. It's a PBS authority. It's not streamlined, unfortunately. Once it's been initiated by a gastroenterologist or hepatologist, though, you can continue to do their authority scripts ongoing. And it's just one 550 milligram tablet twice a day. But it's long-term medication to prevent the next episode of encephalopathy and keep that patient out of hospital and keep them well. We never restrict protein intake in these patients anymore because they're often frail, malnourished, sarcopenic. And the other thing that we do is if these measures aren't working, they keep getting encephalopathy, what you might see us do in the hospital setting is to look for shunts that have opened up spontaneously within the abdomen. So sometimes these patients open up varices that connect their splenic vein to their renal vein. And that will take blood that normally would have gone up through the liver directly into their systemic circulation, directly up to their brain. And if we can knock those shunts off and occlude them, their encephalopathy gets better. So you may see patients where that's being done because we're starting to do it more and more as well. Bone disease is really important. And again, in primary care, you're really good at looking for liver disease, but be aware that Medicare pays for a DEXA every 2 years in patients with chronic liver disease. And they should be getting those because osteoporosis obviously leads to fractures, and fractures in these patients can kill them because the patients with advanced liver disease who fracture their hip, they may not be suitable for surgery and they'll probably die as a consequence. So we want to prevent major fractures. So looking for bone disease and ensuring they've got their repleted vitamin D levels. Preventing infections is very important, and that might be bacterial or viral. So we stop PPIs, as I've mentioned, if there's no strong indication for their use, because ongoing PPIs increases the risk for lots of infection, but including SBP or spontaneous peritonitis and pneumonia. Obviously, we want to make sure our patients get all their COVID vaccinations. And as we heard today, everybody's eligible for a 5th dose, and immunosuppressed patients probably for a 6th dose. And the younger patients under 30 now can get their 4th dose. Annual flu vaccination is really important, and pneumococcal vaccination is actually recommended in the vaccination immunization handbook. Hep A and Hep B vaccination should be given to susceptible patients and can prevent those infections. And patients who have had previous spontaneous bacterial peritonitis, you'll see us continue long-term antibiotics, and that will usually these days be Bactrim or Respirum if we can get it. It may be quinolone such as norfloxacin, which is also a bit of a challenge. And so, as you know, supply of a lot of drugs is challenging at the moment. The other thing that, again, you're aware of from hepatitis C and hepatitis B patients, but also these other patients with cirrhosis, is that HCC surveillance is critical. So we do 6-monthly ultrasounds. We're looking for small nodules. And for instance, in Peter, he's found to have an 18 millimeter nodule in the right lobe of the liver. That's not a diagnosis of liver cancer, and we don't want to tell a patient they've got liver cancer based on ultrasound, but we then do a 4-phase CT, not just a post-contrast scan. We need a 4-phase scan with non-contrast, arterial phase, portal phase, and delayed phase. They can have CT or MRI, and the characteristic features of liver cancer is that it's got arterial enhancement, and that's what's shown on this arterial phase scan here. You can see this nodule is now brighter than the surrounding liver, and 5 minutes later on a delayed phase, it's now darker than the surrounding liver. So that's washout. And we can diagnose HCC just based on that scan appearance. We don't do biopsies generally, unless there's something funny about the features. But that's HCC in this patient, regardless of what the AFP level is. And if we've got a patient who's got liver nodules in this setting, they think it's HCC, we refer them straight into the HCC multidisciplinary team. And again, there's HCC multidisciplinary teams at RPA, at Concord, St. George, St. Vincent's, Prince of Wales, etc. We've all got teams. And you can go through canrefer.org.au, they're all listed on there as well. And HCC is not, again, a nihilistic type diagnosis. It doesn't mean it's all over. We can cure patients where we find early lesions, and we can significantly improve survival even in patients with advanced disease. So we've got loads of therapy. I'm not going to go through a whole talk on liver cancer now, but basically we stage them, decide whether they've just got a tiny lesion such as this patient where he's got very early stage HCC, right up to advanced stage where there's portal invasion, there's extrahepatic spread and metastases, but we've got treatments right through there in patients who have got pretty good liver function, including now immunotherapy that we do regularly, and that improves survival significantly. And we take a patient with, who might have a survival of only 7 months without treatment, now out to 20 months, 2 years worth of treatment on average. So really significant impacts. And it's only the patients who have got really severe liver failure and lots of cancer who are terminal phase, and we probably don't have any treatment options. But we do transplants for patients with early stage HCC as well. So again, not a nihilistic diagnosis. And we do lots of liver transplants. We do in adults about 85 to 90 per year at RPA in New South Wales. And we should be considering a referral for all patients who would benefit from transplant. So generally the age up to about 70, they've got to have social supports, be abstinent of alcohol in general, abstinent of injecting drug use, they've got to be motivated, have liver dysfunction as measured by a child score and MELD score, which I haven't gone into, or refractory ascites or chronic encephalopathy or malnutrition or HCC within transplant criteria, and having no contraindications. And survival is excellent. So the most recent era, the grey and the yellow under here, and you can see in 5-year survivals now up over 90%. So it's an excellent treatment. We've done 7,000 liver transplants on 6,500 patients up to 2020 in Australia and New Zealand, over 2,500, I think, in our program in Sydney. So a lot of transplants happening. So the priorities again, I've talked about all of these things: integrated care between the liver specialist and the CNC at the hospital and with primary care. Treat the treatable cause of liver disease, ensure appropriate surveillance and management of complications, reduce the risk of complications, assess and manage malnutrition and oral health, and consider liver transplant in appropriate patients. And I sometimes do get referred patients directly from primary care to consider transplant, but mostly it's gone up through another specialist who then refers on to me. High rates of what I wanted to really focus on, the high rates of readmission among patients with cirrhosis. So this is recent data, very recent, published from the Queensland group, where they noted, this is from the Melbourne group, 46% of patients were readmitted within 30 days of an index admission with decompensation and cirrhosis. What we want to really do is identify these patients, obviously prevent the first hospitalization, but prevent that nearly 1 in 2 patients being readmitted, because a fifth of those readmissions were potentially preventable. So if we can regularly schedule TAPs, they don't need to suddenly turn up in the emergency department to have a TAP because they can't breathe. If we head things off early, so their patients are under the care of the liver team at the hospital, you call them early, or the patient calls them early, and we can get them onto management as an outpatient. So managing fluid overload, preventing infection, preventing hepatic encephalopathy by continuing the medications that were started in hospital can all prevent those things that get the patients back into hospital. So these were the reasons for readmission: fluid overload, infection, hepatic encephalopathy, and GI bleeding, all of which are potentially preventable. And so making sure that they're getting their ongoing prescription medications. So back to those myths, as I said, we can dispel really all of those myths. So there's been major paradigm shifts that really change the way we're thinking about all this, or the way we're intervening, and the way that we're trying to keep our patients well. There are resources, and these are going to be supplied to you as well through the Gastro Society of Australia. We've got information about fatty liver disease you can supply a patient, about advanced liver disease, and about some of the dietary interventions I mentioned, such as high protein, high energy diet. And these are all available for free downloads. And another resource that you may not be aware of, and this was mentioned by Edmund right at the beginning, is that I'm on the board of a national organisation called the Liver Foundation. We've just launched a new website that has lots of material and information to support your patients. So you can direct your patients to the Liver Foundation website. It's very easy to read. It's sort of at school age, early school age reading level. Lots of information about all sorts of liver diseases, not just fatty liver disease. And the other thing from your point of view is that you will need to do audits for CME, and that we've been working with Think GP, and there's currently on the Liver Foundation website, you'll see a link to a metabolic associated fatty liver disease clinical audit, where you can actually enroll your patients who are eligible and are likely to have metabolic associated fatty liver disease around risk stratifying them, doing that fibrosis assessment, and you can get your CME points on that. So a lot of GPs around the country have enrolled their patients and are starting to enroll a lot of the patients in their practice in that audit. So if you're looking for audits to do, there's a good one. So thank you on behalf of the Liver Foundation, also on behalf of Sydney Local Health District. And I'm going to stop sharing and hand back to Edmund.
Thank you, Simone. Sorry, having trouble with my, here we are. Good, thank you. So yes, we got some questions. So
do you want to, sorry to interrupt you. Shall we just go to Janice, who's going to talk just a few minutes about some of those engagements that we're doing from the health district to GPs, and then we'll come back to the Q&A, sorry.
All right, so we can do all the Q&As in one go. That's good, okay. All right, so I will introduce Janice Jones.
Hi there, Edmund. How are you?
Hello, good, thank you. So now, there's a bit of a echo here. Okay, so Janice, if I may just give a quick introduction for you, please. So Janice Pritchard-Jones is a hepatitis clinical nurse consultant at RPA Hospital. She has been in her role for almost 30 years. In 1986, she provided care to the first liver transplant at RPA. In 1995, she completed her Master of Public Health. Her treatise was focused on hepatitis C. In 2020, she completed a Master of Philosophy, and her thesis described a new model of education for hepatology nurses. Janice is passionate about nurse and GP education. She aimed to raise awareness of liver disease and linking people with liver disease to appropriate care. In her role at RPA Hospital, Janice works in partnership with a range of services, including Hepatitis New South Wales, Drug Health Services, the PHN, and the Public Health Unit. The presentation tonight is on the Integrated Liver Toolkit project. So thank you, Janice.
Thank you very much. I'm really sorry, but my camera isn't working. So thanks for the PHN for inviting me to speak, and great to see so many people on board at this meeting. And I'm going to tell you about a project which we started about 3 years ago now, almost, called the Liver Toolkit. Lydia, can you go to the next slide, please? This project, we put in a grant in 2019 to the New South Wales Cancer Institute, and we were successful in getting that funded. And so our main aims in this project was to use health analytics and develop a Polar tool. Most of you would be familiar with Polar. We wanted a tool to improve patient outcomes through early detection of cirrhosis and liver cancer, exactly what Simone's been talking about in GP practices. as well as improving communication channels between GPs and specialist services. And we recognise this as a problem. You don't always hear back from the gastro-liver specialist, and we sometimes having problems getting communication from GPs. Next slide, please, Lydia. So the project involved building the liver toolkit. That took quite a while. And then recruiting 12 general practices across both southeastern Sydney and Sydney Local Health District. We had 6 GP practices from each LHD. Quite a bit of work went into developing, as I mentioned, the Polar tool. One of the biggest frustrations we have, and it's an ongoing issue, is around extracting hepatitis C and hepatitis B results. As some of you may be aware, we looked at other audit tools like using PenCat, etc., and we've had the same problem. This is because of the way the private labs supply the information into the GP software. And we can't resolve that issue, but we're working with the ministry, etc., maybe to try and resolve it. Once the tool was built and we could start running in GP practices, a registrar from St George and a fellow from Prince Alfred, plus a nurse, plus someone who could do a fibre scan, went out to these GP practices and searched for the patients with possible cirrhosis, and offered them a consultation, offered them a fibre scan, and that was all done in the GP practices. If we can go to the next slide, please, Lydia. So this briefly just shows what the Polar tool extraction looks like. And as you can see from what Simon mentioned, we're interested in knowing what the APRI score was, what the FIB-4 score was. Simon didn't mention it, but there's another score called an NAFLD score. And so the analytics was able to pull out the ALT, the AST, the platelets, and more information about the patient and calculate these scores. We're also able to pull out diagnosis of cirrhosis and BMIs, etc. So it worked quite well. Next slide, please. Okay, so the results today is that within those 12 GP practices, we found about 878 patients without a diagnosis cirrhosis who have the indications for cirrhosis. So we're going through the process now of recalling those patients. So far, it's been quite tricky. Not all the patients want to come back in. As you can imagine, the GP practices have been really busy with COVID. We haven't been able to go out until recently again. So we're still trying to complete this task, and we've seen 113 patients so far. Next slide, please, Lydia. So what's remaining to do in this project? So we're going to want to complete the recall in the next 4 months. And then we're just going to go through a formal analysis where we'll look at the quantitative data. The qualitative data is going to be conducted by the team at University of New South Wales, and they'll be interviewing the GPs and interviewing the team that was involved with that. And the PHN is going to be doing its own separate little analysis. And then a final report will be prepared. And based on the analysis, we'll look at trying to roll out the liver toolkit to all GPs across both the PHNs. Next slide, please. And so our wish list at the moment from the people who've been involved in this is to, hopefully we can keep the liver toolkit going, to refine it, make it more user-friendly. And we want to establish a better estimate to the prevalence of liver disease within our PHN. And understand the causes of liver disease and improve long-term care and HCC surveillance, and improve that linkage between specialist services and GPs. And one of the things, we're looking at a few different tools to do that. Next slide, please. And I want to acknowledge David Prince. He did a lot of work on these slides with me, and he's now a gastroenterologist at Hepatology at Liverpool Hospital. Phoebe Chomley, who's put in a lot of effort into this over the years, and she's a sexual health program officer, and to the GP practices that were involved, and to the GPs that were on the governance committee, and we've had quite a number of committees. Okay, thank you, Lydia. Can I just go to, you can skip that slide because I thought I was going to talk about liver pathways. But just another project we're looking at is trying to open up FibroScans to more GPs. And we're currently looking at the feasibility of being able to do this. And as Simon mentioned, FibroScan is a really useful tool. At the moment, not many hospitals open up FibroScans for a straight GP referral with no consultation. We currently only have that available for Hep C treatment, but we want to open it up for patients with Hep B cirrhosis, MAFLD with signs of progressive liver disease. So then you have to work out the FIB4 before you refer someone, and any other liver diseases. And I presume a number of you would be interested in referring patients for FibroScan. And we've also, in previous years prior to COVID, we were going out to some GP practices, especially when they had a high caseload of GPs. I have had a high caseload of Hep B and FibroScanning in those practices. So we'll be in touch, and there'll be a referral form in Health Pathways once we get it sorted out. And we'll look at taking those green square as well. So thanks, everyone. And that's the end of my talk. Thank you.
Well, thank you, Janice. All right, so I think we should go on to some questions. The first question, Simone, someone asked, is there evidence suggesting that COVID-19 infection, being an inflammatory disease, could trigger off the metabolic associated fatty liver disease?
Not per se, I don't think so. But of course, we know that patients are more likely to get severe COVID if they've got those metabolic risk factors, so particularly obesity, hypertension, hyperlipidemia, etc. And that's co-located with MAFLD. So it's the same patients who are getting MAFLD who are more likely to get more severe COVID. But I don't think there's a direct link mechanistically between COVID and metabolic associated fatty liver disease. Patients with cirrhosis can get into real trouble with COVID. So we do make sure, hopefully, they're all vaccinated and that they get early access to antivirals, because the early data when COVID was first happening, so the early data from 2020 was that patients with cirrhosis who ended up in hospital had a depending on the study, but between a 30 and 35% mortality rate, largely from lung disease. So some of them died from hepatic decompensation, liver failure, but many of them are dying of lung disease. So we need to prevent severe COVID, and a lot of the patients who are at highest risk, as you know, are still trying to sort of avoid it. But I don't think there's a direct link in triggering MAFLD. It's the same patients. It's a problem.
Okay, good. So the next question is about testing liver function tests. So it's the AST and ALT ratio, and how do you use that ratio, and what is a normal ratio?
So I'll take that very last bit. Do we look at it in patients with normal liver enzymes? No, we don't. So I'm only talking about in patients with abnormal liver enzymes. But having said that, that what's normal is probably not what you're used to. So there's a lot of data suggesting that all-cause mortality is increased in men who have an ALT over 30 and women who have an ALT over 19. So a normal value should be under 30 in men, under 20 in women. And that's because all-cause mortality is associated with cardiovascular disease and malignancy, as well as liver disease, and a strong link with obesity, and a strong link between obesity and fatty liver. And the fatty liver may predate a lot of the other manifestations of metabolic associated with metabolic conditions. So we do sort of redefine what's normal. So looking out for subtle abnormal is important, particularly in patients at risk. And then in the more abnormal, the AST-ALT ratio is really important. So I always look at it. And in patients with a severe acute hepatitis, so really high transaminases, maybe in the thousands, where we see the AST much higher than the ALT, we tend to only see that in two conditions. One is in paracetamol overdose and paracetamol hepatotoxicity, and the other is in ischemic hepatitis. So these are largely patients who might be in the hospital with severe heart failure, severe sepsis, hypotension, etc. In the general community, when we see in those lower range liver tests that I showed you in these patients, the AST higher than ALT, you see that in alcohol-related liver disease and in cirrhosis. And the mechanism It's not completely sorted out. It's a very good predictor of advanced fibrosis or alcohol. But one of the mechanisms in alcohol was that these patients get depleted in vitamin B6, which is pyridoxine, and that vitamin B6 is a really important coenzyme for AST and ALT production. But the synthesis of ALT is much more strongly dependent on that cofactor, that pyridoxine, and therefore it will reflect as a lower level compared to the AST level. So that's one mechanism that's been postulated, but there's probably others as well. But it is an important ratio to look at in patients, particularly when it's very abnormal. The other point to say is if the ALT is higher than the AST, that will be consistent with viral hepatitis and with non-cirrhotic diseases as well. And fatty liver disease without cirrhosis often have a higher ALT.
Okay, so actually, while we're on this question about the liver function test, so what about isolated gamma GT, which is quite elevated? So if it's less than 100, does it matter? More than 100, does it matter? And the patients swear they don't drink, and some patients, I believe, they don't drink. And they're not on any medications that could usually affect the gamma GT.
Again, it's another marker. That can be the marker of fatty liver disease. Occasionally you see it if there's lesions in the liver or some compression, or they've got gallstones or something else. Usually it's because of alcohol, I must say, and you just haven't got the history. We're very bad at taking alcohol histories. And why I say that, well, I'm very bad at taking alcohol histories, and I've been doing it a long time. We've now got this test that we're using. It's not out in the general community, but we're using it within our service. And it's a bit like the HbA1c for alcohol. So it tells us about alcohol exposure over the last month, whereas just doing a random blood alcohol only tells us for the last 24 hours or 12 hours or so. So it's amazing. And we're applying this test in patients where we know they've got alcohol-related problems and they say they're abstinent and they agree to be monitored with it, and we find slip-ups. But we also sometimes do it in patients where we think it's alcohol-related liver disease, but they absolutely adamantly deny alcohol, and yet we get a high score. It's called a PEth test. And then we can go back to them and say, actually, you've had this test and it's very suggestive that you're drinking excessively and it doesn't go up in any other condition. And then we get the history. And it's amazing how often I've kind of missed the diagnosis of alcohol. And patients are embarrassed, there's stigma, there's a whole lot of reasons why they won't disclose. But the high GGT is a clue often to alcohol, particularly in conjunction with MCV, which may be a high.
All right, so the next question is about vitamin E, and it just say, well, is there any indication for vitamin E for the metabolic associated fatty liver disease?
So there was a study a number of years ago, which that person who wrote that question may be aware of, that was called the PIVN study, and it was published in the New England Journal, where they randomized patients with fatty liver disease to vitamin E or something else, and I've forgotten the something else at the moment. Oh, I know, it was a pioglitazone or placebo. And the patients with vitamin E had more resolution of their fatty liver disease by the markers that they used in the study. But they excluded patients with diabetes and they excluded patients with cirrhosis. So the pointy end of this, there's no evidence that vitamin E is of benefit, and it's probably of harm. And as you point out, it's been associated with various cancers. So I don't use vitamin E at all. But we're doing lots of clinical trials to try and find a treatment that will reduce the amount of fat in the liver and also reduce the amount of fibrosis in the liver. Many of those studies have been negative so far. And the drugs that are probably the most effective are the same drugs that we're using to get to treat weight loss and diabetes, or to help with weight loss and diabetes. So the drugs that are going to be the most effective are the GLP-1 agonists, and there's studies at the moment underway with semaglutide, and I think that's going to be the front runner until we get to tirzepatide, hopefully later in the year, and they start having factories that can produce these things and we can get supply. But getting weight down and getting the fat out of the liver through those mechanisms are going to probably, I think, be the most effective mechanisms. Bariatric surgery is very effective as long as it lasts as well, and can reverse fatty liver disease as well. And there's other drugs that are in development, but I'm not totally sure how many of those are going to actually come to fruition.
Okay, good. So next question, how long is the waiting time for FibroScan at the moment, or roughly?
Depends on the mechanism of trying to access it. For instance, if a patient is referred to me and I see that patient usually within about 6 weeks, and I do a FibroScan in the clinic on the same consultation. If they're referred, we've got to work out the pathways, as Janice mentioned, for direct access FibroScan. And as we work out those pathways and those channels for getting patients in, whether it's in a community setting or at the hospital setting, those waiting times hopefully will come down as well. But we haven't fully established those referral pathways yet, but they will be available on health pathways when we do. And at the moment, if you do link it with a consultation, we do a FibroScan at the same time.
Okay, good. The next question is more like maybe as a comment. So it says, is there a better public health initiative for dental hygiene, as it seemed to be highly correlated with liver and cardiac disease as well as other diseases? So I think there's a dental clinic at RPA, but I don't think they see.
There is. Yeah, so we refer our patients with complex medical conditions to our dental clinic. But it's limited access, that's a clinic. Dental stuff's huge, as you know, it's not on Medicare, and most of these patients don't have insurance to cover it. And they will, particularly with rising prices in all the other costs of living, dental care goes right down to the bottom of lists. But if we can intervene, it's huge. So it's not just for the primary prevention of the dental stuff, but really if people develop dental decay and periodontal disease, that we actively manage it. But it's a huge problem and under-recognized.
Yeah, okay. So the next question is about the antibodies. So the AMA antibodies, it's at 320, but the SMA antibodies is normal with persistent abnormality of the liver function tests with a mild increase of ALP. So what do you think?
That's primary biliary cholangitis. So you don't see AMA positive in other conditions. So you do see occasionally an AMA positive in somebody with completely normal liver enzymes, and that person is at significant risk of developing PBC later, or clinical PBC with abnormal liver function later. But it's not a marker of other conditions. So if we see abnormal liver tests, and particularly alkaline phosphatase is the main marker, and the AMA is positive, I don't do a liver biopsy in that condition. I diagnose primary biliary cholangitis because nothing else causes that. I do a risk assessment for fibrosis, so I'll do a FibroScan, but I don't do a biopsy, and they all get started on treatment with ursodeoxycholic acid at diagnosis. So it's a really important diagnosis to make, and early intervention prevents progression and prevents the need for liver transplantation in the future. And as soon as we diagnose it, not just an antibody, we've got to have some liver dysfunction, but some liver dysfunction positive antimitochondrial antibody onto urso-fork, and then we make sure that the alkaline phosphatase comes down. It hopefully will normalize if it's early stage disease, but we want to have it less than 1.67 or 1.5 times the upper limit of normal. And if it doesn't, just with urso-fork, ursodeoxycholic acid, we add on second line treatment. As I mentioned, it's on the PBS now, which is Ocaliva. So it's an important diagnosis to make accurately, but it doesn't need a biopsy, and you don't dismiss positive AMAs.
Okay, good. So next one is, it's an ultrasound elastography. How does it compare with FibroScan?
So as you know, more and more the new ultrasound machines have an added feature of shear wave elastography. And so I've seen this all the time. You might send the patient to an ultrasound practice and request a FibroScan. They'll actually do a shear wave elastography on an ultrasound machine. They don't actually do FibroScan. And they're slightly different. The technology is slightly different. And the validation to this point for assessing and having cutoffs for particularly advanced fibrosis and cirrhosis is much better validated with FibroScan at the moment. And I just be wary of reports. I see nonsense reports, and I saw one today where they'll report on ultrasound, the liver is nodular, the portal vein's enlarged, the spleen is enlarged, there's perisplenic varices, the shear wave elastogram was low, suggests no significant fibrosis, where every other feature suggests cirrhosis. So you can get some nonsense reports on them. It's not as well validated as FibroScan, but if you're in a jurisdiction where you can't get access to FibroScan and you need to do another assessment for fibrosis, it's got some worth and some benefit in that context. It's combined with their other ultrasound, but you've got to read the report and it's got to make sense, because they're not trained to report them. it's not that well validated, and you do get these sort of reports that make absolutely no sense at all. So just a little bit of caution, I think.
Okay, so the next one is a patient with autoimmune hepatitis, and it says if the liver function has been normal for about 2 years or more, do they still need a liver biopsy before treatment?
Yeah, so the autoimmune hepatitis is really a chronic condition, and I would say very few of my patients actually get off all treatment. But where we do want to, if we do want to remove treatment, the guidelines do say that liver biopsy is important, because if there's still histologic inflammation on a biopsy, even if liver tests have been normal for 2 years, that patient's at very high risk of relapse if we withdraw immunosuppression altogether. So I don't completely withdraw immunosuppression very often anyway, but if I were to do it, I'd probably do a biopsy or watch them really, really closely. And again, if we do withdraw completely, because the patient often will push us into it, they need to be monitored carefully, and any increase in their liver enzymes, they need to be referred back and get back onto immunosuppressive therapy. And it's a disease that can present fulminant, so they can present with a severe flare of autoimmune hepatitis, turn yellow, develop ascites and everything. So it's a serious condition.
Okay, good. So actually there's no more question, but I since we've got a bit more time, so can I ask whether nowadays, with all the treatment easily available for hepatitis C, is the liver clinic still taking patients for hepatitis C?
Our junior doctors have got almost no experience in treating hepatitis C now. We see very little hepatitis C unless it's complicated. So it's cirrhosis with hepatitis C. I obviously see liver cancer with hepatitis C. I see difficult patients who have failed to respond, we might see. But if a referral comes to me from an inexperienced GP that's not comfortable prescribing, and you should all get experience, I think, and be comfortable in prescribing for the uncomplicated patients. If I get those referral, then often we've got nurses in our clinic, embedded in our clinic, who are very comfortable looking after hep C. They'll take them on. I don't tend to see uncomplicated hepatitis C unless there's a good reason for it, because they're very easy to treat. And again, Health Pathways gives you all those tools, and the Gastro Society of Australia has on its website all the tools as well. And we've shared some of those with you as well after this meeting. That patients who don't have advanced fibrosis, you can assess that with the APRI score, which I didn't go into in detail, but Janice mentioned AST to platelet ratio index. Calculate that on an app. If it's less than 1, just go ahead and treat them. And the treatment's either for 8 weeks or 12 weeks. There's only 2 drugs now really available to do that. It's really easy. Check them for the worked 12 weeks after they finish. And most of those patients don't need to be referred in. And there's a fax referral form that can be submitted. It's on Health Pathways as well. It's on the GISA website. If you're not sure, just fill in all the patient details, fax that into any of our clinics. We will check through everything, sign it off, and indicate that you've picked the right regimen to treat them, and then go ahead and treat them in primary care. They don't need to see us.
Yeah, that's good. That's great. So we've got some more questions now. So should cirrhotic patients on carvedilol have regular fibroscans?
So I tend not to. So once I've already made a decision to put someone on carvedilol and they're at the proper dose, I don't tend to monitor them with ongoing fibroscans. I don't think it gives me any extra information at that point. If they're not on carvedilol, then I'm looking for an indication to go onto it, and I might do. So yeah, not generally once I've got somebody at that stage of liver disease.
Right.
Is FibroScan safe for a pregnant patient? The original label for the FibroScan and the approval actually contraindicated it in pregnancy, but they've actually removed that. So it is safe, but I don't ever see a reason for doing it in a pregnant patient. You can get false results. The liver, they're overall, they're particularly in later pregnancy, fluid volume's up. The liver might be a little bit stiffer in response to that increased fluid volume. Just related to the pregnant state. It's probably not going to give you any information in pregnancy. So I would rarely do it in pregnancy. I'll just bring them back afterwards. But it's not strictly contraindicated anymore. It's safe to do.
Okay, good. Okay, well, we don't have any more questions. So yes, well, thank you very much. It's an excellent and comprehensive presentation. There's quite a few things we have to learn from what you just told us. They're quite different from what we used to do for people with liver disease. So thank you very much for the information, and thank you for Janice as well. Lydia, anything you'd like to add, please?
Yes, thank you very much. I would also like to join Edmund in thanking Associate Professor Simon Strasser. Absolute privilege to host you tonight. Also, Janice Pritchard-Jones, thank you very much for your time. Tammy Shapiro, thank you for your presentation. And also Dr. Edmund Lee, thank you for your support in bringing this session to life. Also, I would like to thank for all the additional materials that have been shared with us. Those materials we have prepared, and it will be sent out just after the session